Hi, I'm Claire. Thank you for joining me today for this informative presentation on pregnancy and health. It is split into three sections. Firstly, covering gestational diabetes, secondly, preeclampsia, and lastly, substance misuse. Gestational diabetes can only occur in pregnancy. It affects around 5 in 100 pregnancies, usually in the second or third trimester, and it can happen regardless of the diabetes status of both conceiving parents. Causes include hormonal changes, insulin resistance, or pancreatic function. During pregnancy, the placenta generates hormones that can interfere with the function of insulin, which is the hormone that controls blood sugar. As pregnancy continues, the body's responsiveness to insulin decreases. This reduces the body's ability to properly use glucose, leading to rising blood sugar levels. The pancreas is responsible for producing insulin. Therefore, the issue derives from its improper functioning, as it has an inability to meet a pregnancy's increased demand for insulin. Risk factors include family history of diabetes, a history of glucose intolerance, ethnicity or race, particularly South Asian and Black, a previous delivery of a heavier than average baby, which would be over 9 pounds or 4.1 kilograms, being overweight with a BMI over 30, and being over 40 years old and pregnant. Previous diagnosis of the pregnant person, including polycystic ovarian syndrome and gestational diabetes in previous pregnancies. Prevention of gestational diabetes cannot be guaranteed. However, it is recommended to begin or continue healthy habits before becoming pregnant. These include staying active, eating healthy foods, especially fruits and vegetables, and those high in fibre and low in fat, and starting pregnancy at a healthy weight. If gestational diabetes is not managed, the mother's body may not be able to produce enough insulin in order to meet the requirements of a healthy pregnancy. This can cause many issues. Examples include preeclampsia, an overproduction of amniotic fluid which can provoke premature labour, a substantially large baby increasing labour and birth risks, a jaundiced and or low blood sugar baby following birth, stillbirth, or developing type 2 diabetes after the pregnancy, which is a long-term type of diabetes. Potential signs and symptoms of gestational diabetes include being thirstier and having a dry mouth, headaches, needing to urinate more frequently, fatigue, developing urinary tract infections, thrush, dizziness and lack of balance, blurred vision, and fetus measurement being larger than average. During antenatal appointments, risk factors are explored and identified along with any signs and symptoms that are potential links to gestational diabetes. In order to diagnose gestational diabetes, the patient is offered an oral glucose tolerance test, also called an OGTT, which involves fasting for 8 to 10 hours prior to the test, a blood test to determine blood glucose levels, consumption of a glucose drink, and another blood test after 2 hours to see how the glucose affected the body. The OGTT usually takes place in a hospital, antenatal or diabetes clinic. Overall, it should last around 2 to 3 hours. The results of an OGT show measurements in milligrams per deciliter or millimoles per litre and indicate whether a woman has normal blood sugar, impaired glucose tolerance or pre-diabetes, or gestational diabetes. A blood sugar level below 140 milligrams per deciliter is generally considered within the normal range. A blood sugar level between 140 milligrams per deciliter indicates impaired glucose tolerance or pre-diabetes. In this case, further testing may be recommended. A blood sugar level of 190 milligrams per deciliter or higher indicates gestational diabetes. In this case, a midwife explains the diagnosis to the patient, and further appointments will be scheduled for recommendations and monitoring, usually with a dietitian and an antenatal or diabetes clinic. The focus will be on managing the patient's blood sugar levels through diet, exercise, and potentially medication. Diabetes can affect the baby's growth, whether it is in its embryonic or fetal stage, and cause issues with its breathing. It can also increase the likelihood of the baby becoming obese and developing other health problems from birth. As for the patient, there is an increased risk of developing preeclampsia, increasing the risk of early labour, an emergency C-section, and developing type 2 diabetes later in life. Therefore, it is critical that the diagnosed patient understands that attending follow-up appointments is of the utmost importance. A gestational diabetes care plan is a patient-specific plan created by a team of healthcare professionals. It focuses on controlling high blood sugar levels during pregnancy in order to keep blood sugar within a healthy range for both mother and fetus. This approach often includes regular blood glucose monitoring, dietary supplements, physical activity, and potentially insulin usage. In addition, a blood glucose monitoring kit may be given to the patient so that they can regularly check their blood glucose levels at home or on the go, as well as information on how to manage blood glucose levels that are too high or too low. Preeclampsia is a serious pregnancy complication characterised by high blood pressure and signs of organ damage, usually occurring after 20 weeks of pregnancy. It can affect the mother and the fetus, potentially leading to serious complications if not managed properly. While the exact cause of preeclampsia remains unknown, it is thought to be caused by problems with the placenta's development, particularly with the blood vessels supplying it. In the UK, preeclampsia affects approximately 1 to 5 in 100 pregnant women. During the first antenatal appointment, the midwife will review the patient's medical records and ask questions to identify any risk factors for preeclampsia. Risk factors include being over 40 years of age, having a BMI over 35, a family history of preeclampsia, a previous premature birth, being pregnant with twins or more, the last pregnancy being over 10 years ago, and previous diagnosis of kidney disease, high blood pressure or diabetes, or an autoimmune condition. High blood pressure and protein in the urine are the first signs of preeclampsia. Thus, a blood pressure check along with a dipstick in a specimen of urine will be conducted at each midwife appointment. This could detect preeclampsia in its early stages, before the patient notices any unpleasant signs or symptoms. Common symptoms of undiagnosed preeclampsia include blurred or flashing vision, nausea and vomiting, long and severe headaches, pain below the ribs on the right side, and sudden swelling of the face, hands, or feet. Less common symptoms of undiagnosed preeclampsia include sudden weight gain from fluid retention, reduced urination, breathing difficulties, and a slow fetal development rate. Preeclampsia is associated with slow development, as the condition limits the fetus's oxygen and nutrition, resulting in stunted growth. The phrase small for gestational age, or SGA, refers to the slow growth rate, usually detected during fundal height measuring or an ultrasound scan. A preeclampsia care plan is a patient-specific plan aimed at reducing the risks and problems associated with the condition. Preeclampsia treatment varies based on the severity of the condition and the stage of pregnancy at which it is identified. If preeclampsia is identified but the blood pressure is found to be within a normal range, the patient will be seen weekly to have blood pressure and urine protein levels checked. In addition, ultrasound scans will be performed more frequently than usual to monitor the fetus's health and growth. Blood tests will also be performed to assess changes in kidney function, blood count, and electrolytes. Transaminases and bilirubin are checked for, as these indicate liver problems. If blood pressure remains high, beta blocker medication is considered, as they help to lower and maintain blood pressure levels. The beta blockers are taken until blood pressure returns to a normal range, which usually exceeds birth. If the patient's blood pressure remains high and the condition has an impact on her and the fetus's health, hospital admission for closer monitoring may be necessary. Depending on the stage of pregnancy and the severity of the preeclampsia, labour may be induced. as the only way to entirely get rid of preeclampsia symptoms is to remove the placenta from the patient's body, which inevitably involves removing the fetus too, because the fetus relies on the placenta for survival. This can be done through vaginal birth or a caesarean section. Before 34 weeks, relief may involve taking medication to reduce blood pressure for both mother and fetus. From 34 to 36 weeks, relief may involve taking medication along with close monitoring at hospital or clinic. If medication fails and the health of either the patient or the fetus is declining and significantly impacting organs, inducing an early labour is considered and scheduled. Medication failure and deteriorating mother-fetal health at 37 weeks would require immediate action involving induced labour or a caesarean section within 24 to 48 hours. The care plan does not stop at birth because in some cases preeclampsia can persist beyond this point and the mother can develop postpartum preeclampsia. This occurs when the blood pressure stays high, protein is still found in the urine and preeclampsia symptoms persist. If preeclampsia is left untreated before or after birth, it can develop into eclampsia, which can cause death. Eclampsia is rare, affecting around 400 women in the UK per year. It presents as seizures and usually occurs in the third trimester or after birth. It can occur due to poor management or cooperation during preeclampsia care. It comprises excess blood pressure on blood vessels which leads to brain swelling, ultimately causing a seizure, which is when the body convulses and shakes due to a malfunction of electrical impulses from the brain being sent uncontrollably to the muscles. This is dangerous for the patient and increases the likelihood of further body damage, especially if the seizure involves a hard fall. Eclampsia can also cause the patient to suffer organ damage, cardiovascular disease, stroke and HELLP syndrome, which is hemolysis, elevated liver enzyme and low platelet count. Severe afterbirth bleeding can also occur. Issues for the developing fetus include a lack of oxygen and prolonged preeclampsia symptoms, including restrictions of blood, nutrients, growth and weight gain. If eclampsia occurs, labour is induced along with the medication magnesium sulfate in order to limit seizures. However, in most cases, a caesarean birth is the most viable option. Eclampsia symptoms usually stop after birthing the placenta and baby. However, sometimes it can take several weeks to fully recover. Consuming alcohol while pregnant poses numerous risks to both mother and fetus. If alcohol is consumed, toxins from the alcohol will enter the fetus's bloodstream via the placenta and interrupt organ development, causing significant damage to the fetus. Alcohol consumption in pregnancy is apparent in the fetus from its slowed down growth rate and low weight at birth. It may also be apparent through the diagnosis of fetal alcohol spectrum disorder, also called FASD. As previously mentioned, slow fetal growth can be defined as SGA, which again is small for gestational age. SGA increases risks such as premature labour, miscarriage and stillbirth. The baby is classed as having a low birth weight if it weighs 2,500 grams or less when born, ultimately causing issues which can include breathing and feeding difficulties, low blood sugar and an underdeveloped layer of fat required for keeping organs safe and keeping body temperature warm. FASD is a neurodevelopment disorder. It occurs from alcohol consumption during pregnancy, ultimately affecting the fetal organs, including the brain. This causes detrimental effects on the fetus's future emotional, cognitive and neurological development. Furthermore, it is likely to encounter learning difficulties, behavioural challenges, delayed speech, delayed mobility and development issues in the joints, muscles and organs. Due to these extreme consequences, the mother is advised not to consume alcohol through food or beverages while pregnant. All forms of illegal and recreational drugs taken in pregnancy affect the growing fetus as they enter the fetus's bloodstream via the placenta. This can have tremendous impact on the health of both fetus and mother, including premature birth, low birth weight, miscarriage, or stillbirth. Potential complications specific to consumed drugs include premature labour and low fetal birth weight from cannabis, premature rupture of membranes and a placental abruption from cocaine, increased likelihood of the fetus having motor development complications and birth defects from ecstasy, and an increased likelihood of sudden infant death syndrome, also called SIDS, and withdrawal symptoms in the fetus once born from heroin. Heroin withdrawal symptoms that are present in the newborn baby are known as neonatal abstinence syndrome, and it occurs directly after birth. NAS symptoms include irritability, scratching, rapid breathing, high-pitched crying, shaking and tremors, and an inability to settle or sleep. In cases of NAS, the baby will require extra observation and monitoring and may be moved to a neonatal unit, where medications may be given in order to further support the newborn. Advice, support and guidance are offered through the NHS to pregnant people who are suffering addiction. Support is available through the mother's midwife, GP, addiction services and addiction charities. Whether alcohol or recreational drugs were used prior to the pregnancy and whether the mother was aware of her pregnancy or not, healthcare professionals will provide a non-judgmental service and encourage honesty. This is done in order to understand, empathise and offer the best possible solution in ensuring the mother and the fetus's health and well-being. We have now come to the end of the presentation. If anyone has any private questions or would like to be forwarded further information on any of the topics discussed, please feel free to email me after the presentation, and I will reply as quickly as I can. If you have any general questions that you would like answered right now, please raise your hand. Thank you.